We'll get into cranial nerve 9 now. So cranial nerve 9 is sensory and motor. Originates in the medulla. Provides motor innervation to one muscle, the silopharyngeus muscle. It does have some contributions to some of the laryngeal muscles. Typically, EMG would be used from the silopharyngeus muscle, but it's very hard to access, and if you were going to use it, you'd have to have an ENT surgeon actually do a dissection to get there. So we're going to show you a technique on how to monitor cranial nerve 9 without having to do silopharyngeus. And that technique is actually sticking the needles in the soft palate. The soft palate is really cranial nerve vagus innervated, cranial nerve 10. So you're really getting a far field EMG. It's not a you're not in a cranial nerve 9 innervation. Basically, patients that have a lesion to cranial nerve 9 are going to have no gag reflex. So, again, we talked about the silopharyngeus muscle. The muscle is so small that on my virtual cadaver, it doesn't even show up. So, like I said, we use a soft palate. You're going to get 2 needles to the back of the mouth. And basically, the electrode should be placed after the patient's intubated. And everything in the mouth needs to be put in the mouth. And the tube is secured. The way I anchor these electrodes, because you can't anchor them when they're in. You can't get any tape in there to hold them. Now, sometimes what I'll do is I'll hook my electrodes so you can get them kind of in and hook them. I think Rhythm Link, and I'm sure other suppliers, also sell hooked EMG electrodes that have that ability. If you can get in there without the hooks, it's fine. You have to tape it, kind of anchor it to the chin. It's the best way to do it. And what I usually do is, if you're doing 9, you're probably doing 10, 11, 12 as well. So once a tube is in, put 9 in, put 12 in, and then take both those electrodes, stress loop, tape to the face. You don't want these getting pulled out intraoperatively. You can't access them at all. And so that's the best way to do it. And then what I do is I'll tape over the mouth. So I will actually put a piece of tape or tegaderm over the mouth so nothing falls out. And it works well. Cranial nerve 10, the vagus nerve. It's the longest cranial nerve in the body. It's sensory and motor, originates in the medulla, provides motor innervation to most of the laryngeal and pharyngeal muscles, controls muscles for voice, resonance. It innervates the palate, the soft palate. It provides parasympathetic fibers to nearly all thoracic and abdominal viscera. Now you can do EMG in the soft palate as well. That's a direct cranial nerve 10, indirect cranial nerve 9. You can do the recurrent laryngeal nerve for cranial nerve 10. And you can do the cricothyroid muscle, can also be utilized. Damage to cranial nerve 10 can cause bradycardia, which is slowing of the heart, or reduction in blood pressure. If you injure the recurrent laryngeal nerve, you can have a hoarseness or a loss of the voice. You can lose palate elevation. You can actually, if you hit the superior laryngeal nerve, you can have a timbre issue where the timbre of your voice changes. So the nerve exits the brainstem and sends out innervations to the pharyngeal and laryngeal muscles. It comes down and then it gives off its recurrent laryngeal nerve around the arch of the aorta, and the arch of the aorta on the left side and the subclavian on the right side. So here's the recurrent laryngeal nerve, here's the vagus nerve, and here it keeps on going, but then it kind of goes around the arch of the aorta here, behind it, to come back up to the recurrent laryngeal nerve, and I think I zoom in here to show you. So here's the recurrent laryngeal nerve here and here, right, and then it comes back. So if you're doing, we're talking about skull-based procedures, you guys I'm sure are aware of recurrent laryngeal nerve monitoring for ACDFs and thyroidectomies, and but you can do it. Recurrent laryngeal nerve will cover you for skull base. So if they have the tube, or you have the dragonfly electrodes or whatever, you can do it. You can also find the cricothyroid and put your needles in kind of superficially in the front of the neck to cover the cricothyroid. That's fine. Or you can do soft palate. Just you have to remember that when you're doing any of these three, so soft palate, tube, cricothyroid, that's fine for skull base, all three of them. If you're going to do a cervical case or a thyroidectomy, you can't do the soft palate, and you wouldn't be doing the cricothyroid because you couldn't get to it. And the cricothyroid is not innervated by the recurrent laryngeal nerve, it's innervated by the superior laryngeal nerve. They are good to monitor in thyroids, but I want to make it clear that you can't do all three of these for recurrent laryngeal nerve monitoring. You could do it for vagus nerve monitoring in a skull-based procedure. Because I know that comes up. I think it was Jenny that had asked me that question not too long ago, and she just needed a refresher on why. But basically, this is specific to recurrent laryngeal nerve monitoring during ACDFs and thyroids. All three of these can be used because you're at root level. You're in skull base, you're the brainstem, you're at the root. You're before any of the branches occur, which is why you can effectively monitor all of it. The same thing with the facial nerve. You're at root level, so you don't need to monitor necessarily all the branches of the facial nerve. Now, cranial nerve 11, spinal accessory nerve, and I just want to point out, this is one of those nerves, one of the three nerves that doesn't originate in the brainstem. It originates in the upper spinal cord. And it innervates the trapezius, correct. So what happens is it starts down here in the upper spinal cord, and it comes up through the foramen magnum, and then it comes back out. I forgot the foramen, it comes back out, but it comes back out to innervate the sternocleidomastoid and the trapezius muscles. So, EMG in the sternocleidomastoid or the trapezius muscles are fine, especially in a skull base procedure. Either one works. I usually go to the trap every time. Damage to cranial nerve 11 causes a winged scapula, inability to shrug the shoulders. So here's sternocleidomastoid. You can place EMG needles there. Here's cranial nerve 11 right there in a surgery I did. And then this is what a winged scapula looks like. Or you can do the trapezius. What's nice about the trapezius muscle is that you don't need to be in the back. You can get it in the front. It wraps around the front. And what I usually do, even for my cervicals, is I usually, right at the top of the muscle, I grab it. So, you can get it right in the front here. Or you can go to the back, because it's a big muscle. You go right around the shoulder there. And cranial nerve 12. Hypoglossal, motor only, originates in the medulla, so there it is there. Provides motor innervation to the tongue, as seen here. And we use EMG of the tongue. And I've said this before, the tongue is the hardest muscle to put your needles into. For whatever reason, it just doesn't go in. The best way to do this, if you can, is doing cranial nerve 12 and 9 are just technically difficult because you have a tube in the way. You got to make sure you don't do something to that tube, obviously. The best thing to do is to get that tongue and try and get it out of the mouth a little bit so you can grab it. Do that with a pair of gauze, and you just kind of pull the tongue, and you just want to hold it and stick. And very difficult to get the needles into the tongue. It's very, for whatever reason, the way the muscle is made, it's not as easy as sticking it into through the skin. So you want to get the mouth open, grab the tongue. I usually do it like I get a tongue depressor and a piece of gauze, and I grab the tongue out, and then I hold it with a tongue depressor, and I stick the needles in. And just to go back, I'm sorry, to cranial nerve 9, what I'll do is I'll take a pair of hemostats with, sterile hemostats I'll ask from the field, and I will kind of clamp my needles, not to where they're damaged, but enough that it holds it so I can get back to the soft palate. It's very hard to get, at least I can't get my hands back into somebody's soft palate with a tube in the way, and and everything else going on there. So monitoring the hypoglossal nerve should be done when they're when they request it, when they're operating around the foramen magnum, any kind of lower skull base, occipital, suboccipital. It's when the nerve can be damaged. So this is again from Augie Moeller's book, and this is just showing you setup for a number of EMGs. So they have 7 and 12, and it shows you the extraocular muscles, and 5, even though 5 is probably really down here. And then bears they kind of show, and they have a contact lens they use for their VEPs, which is kind of showing you a setup here. So one surgery that can affect cranial nerve 9 and 10 is the microvascular decompression for vagoglosopharyngeal neuralgia. So vagoglosopharyngeal neuralgia is cranial nerve hyperactivity pain syndrome leading to severe transient or sharp pain in the ear, base of the tongue, tonsillar fossa, and beneath the angle of the jaw, corresponding to the distributions of the auricular and pharyngeal branches of the cranial nerves 9 and 10. Swallowing, chewing, talking, coughing, or yawning commonly trigger this pain. These painful attacks are neuralgic, lasting for less than a second or as long as a few minutes. And the surgical procedure that has the highest rate of pain relief is a microvascular decompression of cranial nerves 9 and 10. Usual cause of this neuralgia is compression of the 9th and sometimes the 10th nerve by a blood vessel, which is usually the posterior inferior cerebellar artery, which I have highlighted here. So this is kind of showing you 9 and 10 coming out, and they're highlighted. So here's 10. Here's the vagus ganglion here. Here's 9, and you can see here's the pica. So that that vessel compresses the nerve, and they go in there just like any other microvascular decompression. So basically you would do EMGs for vagus and cranial nerve 9 on this case, but also obviously auditory vote potentials and other cranial nerves that can be affected here. You talk about 9 and 10, you probably do 11 because here's 11 here. You probably do 12 and probably 7 as well. You probably do a range of cranial nerves for this specific procedure. And this is just showing all the cranial nerves with the vasculature, just so you get an idea of what's really, because you've kind of seen the cranial nerves independently. Here they are all together with the vasculature. You kind of get an idea here. So here's 2, 5, 1, 3, 3, 4, and 6, 7 and 8, 9, 10, 11, and 12 are over here. You can see 11 coming up here. Like I said, the vagus ganglion there. And then you can see all the vasculature. So there's a lot of vascular injury that can occur in these surgeries, as well as neural injuries. Let that run through, so you get an idea of what's going on here. Any questions on cranial nerves as we move into other areas? So one of the procedures that you can monitor, you simulate cranial nerve nuclei, is mapping the floor of the fourth ventricle. So basically, the floor of the fourth ventricle, this is considered the floor of the fourth ventricle. It's kind of this back part of the fourth ventricle. So this is the fourth ventricle here, and this is the floor, right up against the brainstem here. Basically, you have your cranial nerve nuclei living there. So operations inside or around the brainstem are delicate. There are many structures that are located basically with a very small volume of brain tissue here. And if they have to go here, you can map the floor of the fourth ventricle by putting a stimulator in there and actually mapping each cranial nerve nuclei. So you'd obviously cover your cranial nerves that you're looking at with motor components, obviously, with the EMG electrodes, and you'd stimulate and you'd activate so you know where you are. And basically you map it out so you know what you can take. So just showing you. So the floor is not down here. The floor is really considered this more kind of ventral side of the fourth ventricle. That's the floor. Just kind of give you an idea of it. So motor structures can be identified by electrically stimulating the surface of the floor of the fourth ventricle and recording EMG responses from the muscles that are innervated by those motor systems. Using this method, the seventh cranial nerve can be identified and as well as other cranial nerves. Such recording can distinguish between the two sides of the hypoglossal. So you can actually differentiate the hypoglossal, indicate which side is being stimulated. Cranial nerve 9 and 10 can be identified using similar methods. Electrical stimulation on the floor of the fourth ventricle should be done with extreme caution. The lowest possible stimulus should be used. I mean, you're starting at like 0.5 milliamps, maybe 1 milliamp. Stimulus repetition rate should not exceed basically 10 hertz. And although 5 hertz is generally a better choice, so you're a little lower, anything lower than 5 hertz, you can do 2.7, you can do 4.7. And you want to do short duration impulses with about a 50 to 100 microsecond pulse width. And basically, because they're going into the brainstem here and they're stimulating, and then you can get action potentials from 7, 12, 7. You can basically get all of these action potentials by doing this type of mapping. And this is not monitoring, this is mapping. It's completely different. Mapping and monitoring are two different things. All you're doing is identifying structures when you're mapping. Another procedure, when you talk about lower cranial nerves, it's going to be acoustic neuroma surgery. Acoustic neuroma is a tumor. It grows from the nerves responsible for balance and hearing. It's usually called either an acoustic neuroma or a vestibular schwannoma. These tumors grow from the sheath covering the vestibulocochlear nerve. Acoustic neuromas are benign, so they're not cancerous, and they grow slowly. Over time, the tumor can cause gradual hearing loss, ringing in the ear, dizziness. The bigger it gets, it starts impinging other structures that can cause issues, maybe even swelling in the brain. Because of their slow growth, not all acoustic neuromas need to be treated. And it's usually observation, surgery, and then radiation. High risk of facial nerve damage when they go into these procedures. And also high risk of trigeminal nerve injury. And an acoustic neuroma expands out of the internal auditory canal, displacing the cochlear, facial, and trigeminal nerves located in the CPA. So here's normal, here's with a tumor. One of the problems with these types of tumors is that they can split the nerve, they can split the seventh nerve as they grow. So you end up with the seventh nerve on both sides. It's a very invasive tumor, and it's a very dangerous surgery. The longest surgery I've ever been on was an acoustic neuroma resection for 26 hours. Because they just pick and stim and pick and stim and So here's acoustic neuroma, small, medium, and large. So surgical removal, usually there's 3 priorities for surgical removal for doing a craniotomy One is the maintenance of facial nerve function. They do in most cases want to try and preserve hearing if hearing is not compromised already. And they want to try and get the entire tumor out. Total tumor removal may result in a cure. It also carries a higher risk for hearing and facial nerve damage, because if they can't marginalize it and they take the whole thing out, you're more chance of damaging the other cranial nerves. There are several approaches for acoustic neuromas that can be done. So the first one is your retrosigmoid approach, and this is what we're probably most familiar with. It's just suboccipital approach to the posterior fossa. So this approach may be used for all tumor sizes, but especially larger ones, because preserving facial nerve function and in hearing is important in this approach. So the advantage of this approach, again, any size tumor can be attacked. Hearing preservation is possible with this approach. You get a wide exposure of the brainstem and lower cranial nerves. The disadvantages is it must be the tumor itself must be medially located no greater than 2 centimeters from the CPA extension. Lateral tumors risk injury to the endolymphatic sac and vestibular labyrinth. Cerebellar retraction can cause, obviously, issues to the brainstem. You can also have ocular motor abnormalities and post-op disequilibrium. And also, with this approach, you're more at risk for an embolism, depending on if you're in a sitting position, which sometimes they do, or the park bench position. Another type of approach is the translabyrinth approach. They do this, basically the semicircular canals are removed to expose the tumor in the internal auditory canal. Because the canals are removed, complete hearing loss occurs. They sacrifice the 8th nerve on this approach every time. The advantage of this is that there's the least cerebellar retraction with a wide exposure of the posterior fossa. There's no size limit for resection, and the facial nerve is easily identified. The disadvantage is that you have to sacrifice the nerve, and you also have to put a fat graft in there, so they'd have to do abdominal surgery as well. The third approach to this area for an acoustic neuroma is a middle fossa approach. There's a middle fossa craniotomy. It's made above the ear in the temporal bone. Advantage of this is that this is the best for hearing preservation. And you get good exposure of the vasculature in this one. The disadvantage in this, though, is it's limited in your size. You basically, the tumors have to be kind of less than 2 centimeters in dimension. So it's for small tumors. Another disadvantage is that you have to actually retract the temporal lobe in this one. You must dissect around the facial nerve because you're going in kind of superiorly. So instead of going kind of underneath, you're going in towards the facial nerve. So you have to dissect around. This is much more dangerous. And also, when you go this approach, you're opening up yourself to other cranial nerves, 3, 4, and 6. So if you're going to do a retrosigmoid or posterior fossa approach, modalities we would use are bears for 8th nerve function and brain stem. Cranial nerves, basically 5, 7 through 12, depending on the surgeon. The surgeon's going to tell you what he wants. But these are what you kind of put in your head when you get this booked. You know, because we're looking at this area here. Basically, you want a game plan. If you don't know the surgeon, you don't know what he wants, you're going to have a game plan. I'm going to want to try and do 5, 7, 8, 9, 10, 11, 12, and then the surgeon will tell you what he wants. And that's true for any surgery. Like when I did my trigeminal neuralgia a couple months ago, and I was going to go in and do cranial nerve 5, and he was like, I don't want it, I want 11. So, you know, you have a game plan and the surgeon changes on you, that's fine. Just the idea is you have to know what you want to bring into this. SSEPs, definitely, your vertebral arteries are coming right into that area. So you definitely want to do SSEPs. So a middle fossa approach, again, bears for eighth nerve function and brainstem function. This time, your cranial nerve EMG, you're going to add your extraocular muscles, because now you're coming in through here. Here's your extraocular nerves. Fifth nerve you're going to have. So, you know, they're going to right here. So they're going to come down this way. Seventh nerve, obviously 5, and I would do all the extraocular muscles. And then SSEPs, because your internal carotid artery is going to be right over here, and the branch off to the MCA and ACA. So this is just kind of showing what the approach looks like, and you can see you have the lower cranial nerves here, 7 and 8, and then here's 5. So everything's kind of close together. It's very small in real life. Up here is showing you a tumor. And when we do EMGs in these cases, we're also thinking about triggered EMG as well. You're not just going to do free run, but you're going to probably trigger, especially in the cases like this where they're not, you know, really sure about the anatomy or did the nerve split and they want to see if it still functions. So they're going to stimulate, you know, with a stimulator, which we're going to get into. The next surgery is CHIARI malformations. Basically, CHIARI malformation is when a portion of the brain herniates, pushing through the opening of the base of the skull. And these are the cerebellar tonsils, or what actually herniate. You see them here. So this is where they usually are. And they herniate down. And this is a midline suboccipital approach. So still posterior fossa, but it's a midline approach. It's not behind the ear. It's a midline approach. And a small portion of the skull is removed, and protective covering of the brain is open. That's the dura. It's opened. CFS flows between the dura and the brain. And basically, they open that and they do a laminectomy at C1. So basically, what they do is they open up the dura, they do the laminectomy, and then they basically put a patch just to create room. But basically, all they're doing is, it's kind of like, you guys ever been in a laminoplasty for a cervical laminoplasty? So basically, cervical laminoplasties are done specifically for stenosis. So when you have central stenosis type, all they do basically is they take a laminoplasty is they cut down the lamina on one side of the spinal column, and they open the lamina and they put wedges at each level. So it's usually like a C3 to C7. And they'll put wedge every level. And all that does is basically opens the canal. That's all they're doing here, is they're opening the pressure. Because you just have all this pressure that's, you know, causing hydrocephalus and other, you know, nasty things. They just want to, but it's a dangerous procedure because A, you're right at the base of the brain. So, right, we'll do bears, we'll do SSEPs. You know, maybe we'll do lower cranial nerves, depending on what they do. I mean, they really shouldn't get into the cranial nerves